Today we'll talk about cancer for a bit. Okay. So cancer, again, as I said last week, this slide is pretty important. Like the numbers are good to know, just because in case you're asked what's the most common cause of cancer deaths by the sex, or by what's the greatest cancer incidence, or like the fourth highest, or something like that. Like you can just look straight onto the chart and then get it from that. The ones that I would say especially to note are the sex organ cancers, like breast and prostate. Those are the highest incidence, but they're not necessarily the highest killers. Lung is typically the highest killer, but second highest incidence. And then pancreatic cancer has like kind of the highest relative percent death, like as opposed to incidence. So it's like even though you only find it 2% of the time, it kills 6% of the time. So it's pretty deadly if it's in the system because it's so small and you typically can't find it. Terminology to note, I would say if you can't memorize these different words, like it's good to have it on your cheat sheet, I think. But also, just for kind of like future reference, like these words are good to know. Like stroma is more of the tissue, parenchymal is more different unique organs, and then mesenchymal or mesenchymal, they have to do with original cells that are in the mesoderm, so it's kind of a different layer in the cells than like some of these more like epidermal kind of cancers. Oma refers to just a regular tumor, but then carcinoma has to deal with epithelial malignant tumors. So when you have the carci in front of it, it's bad. Adeno is for something that secretes, so it's glandular tissue, glandular. And then sarcomas are mesenchymal origin, again, referring to these guys over here. And then blastoma. Blast is typically a word you'll see when it's like building something. So an osteoblast is a cell that builds bone. So a blastoma is a malignant tumor of precursor cells, so something that like makes more of that specific tissue or organ. Leukemia, lymphoma, and melanoma are ones that don't follow this sarcoma carcinoma naming.
I have a question.
Yes.
What exactly do they mean by like
neural crest origin? It's kind of like when you're talking about developmental stages. The neural crest is like a kind of, it's like something that will give rise to all of the other parts of like a brain, for example, or it's like, if you can imagine, I don't know if you've seen pictures of kind of like the embryo and how it kind of like folds out, but like they have a picture of that for how the brain looks when it folds out.
Yeah.
And so it's the neural crest, it like different parts, like the front of this kind of organism looking thing is like, your cerebrum, and the back is for like the brain stem. And it's like if you've ever heard of, there's a type of cancer called glioblastoma, and that's like a brain tumor. And so like neural crest origin can refer to like for the brain, and mesodermal is just like different parts that kind of relates to these guys over here.
Okay.
So you can progress from dysplasia to neoplasm. So you can have so dysplastic does not necessarily mean it's tumorous, like a cancer, invasive cancer, but neoplasm will signify that it is like malignant in nature. It is like kind of a bad cancerous cell. And then these tumor stages are good to note as well. So with tumor stages, you'll have grading. So the T for tumor is based on size, so how big it is. Like, is it in the site versus has it all the way invaded to another organ? Same with lymph nodes. No lymph nodes versus lymph node involvement around the entire system. And then lastly, metastasis is either no or yes. And when you have M1, that's always like the stage 4 cancers, and then these are kind of a variation off of like T0 and N0 through 4. Also with benign versus malignant tumors, benign tumors are the ones that you can see pretty easily and you can cut them out pretty easily with surgery. They're non-metastatic, not as dangerous. The location might be dangerous, which is what might be a problem, but malignant tumors always are pretty dangerous. They are metastatic, they can be metastatic. Poorly differentiated, so it's very difficult to tell these guys apart from like your normal tissue. And then it's like when you cut it out, you can't tell that you cut all of it out because sometimes it's kind of blended in with other surrounding parts of the tissue. And so remember, cancer is a genetic disorder, and so you have one cell that branches into other types of cells. In this tree diagram, what it's showing is like you have a tumor cell, it got a mutation, and then it expanded out like, oh, more of these kinds of tumor cells. But then it acquired like a second mutation, and then you made more lines of it. And then this other type of cell got another mutation, and then another mutation, and then eventually you have this entire like conglomerate of different tumor cells that have acquired various mutations over time, and together they make up this kind of tumor mass. So there's like two different theories about tumors, like either it's one cell, like a tumor is all one cell type, versus it's like multiple different cell types that kind of blend it all together. But cancers are genetic in nature, genetic diseases. So you have two types of genes that, when they're mutated, they can make you more predisposed to getting a tumor or cancer. So you have proto-oncogenes. So proto means before, oncogene means it's a gene that will promote oncogenic, so cancerous growth. So proto, because it's before, when it gets mutated, becomes just an oncogene. Tumor suppressor genes, you need 2 copies for it to be bad. So this refers to loss of function, and the loss of function is typically for like losing a checkpoint function, losing a guardian type function. So then when you knock this out, you will have like, you're more predisposed to acquiring other mutations because your normal cell like won't be able to correct for problems. Whereas a proto-oncogene, when it's an oncogene, promotes growth, like active growth. So that's why it's gain of function versus loss of function. Does that make sense?
I think so.
Okay,
So the proto-oncogene is like you said, it promotes growth, whereas the tumor suppressor gene is just like a checkpoint is missing, so it like gets by.
Yeah.
Okay.
Yeah, exactly. So with proto-oncogenes, the ones to know, like I would throw all of these onto your cheat sheet. So BCL2, HER2, MYC, and RAS. And you don't need to know which types they cause, just know that they are a proto-oncogene.
Okay.
So the one to know from this list that like is specifically talked about is RAS. And translocations that we talked about earlier, those have to do with when a 2 parts of a gene or like a chromosome have like been put together. So sometimes chromosome 1 with chromosome 5 could have some sort of genetic mixing. And this mixing could be a problem in that, one, you could have a transcriptional activator, like a promoter region from one gene that like makes the second one have more protein churned out. So like if you took the region that makes a lot of A, and then you took that region that like makes stuff in general to put it in front of B, and you just start producing a lot of B, it could be bad to have a lot of B in the system. And the second problem is like if you have like a mutant C and a mutant D, like, and you put the 2 together and you made like protein CD, like that could also be a problem with these novel fusion proteins. Tumor suppressor genes, again, they regulate the cell cycle. They negatively regulate it by suppressing the development of tumors. So p53 and retinoblastoma RB1 are the ones that are specifically talked about, and you have to have 2 mutations for it to actually be like especially bad. BRCA1, the breast cancer and ovarian cancer genes are pretty important to know, just like coming out of all of this, but p53 and RB1 are the ones especially noted for this exam. So you have 6 hallmarks of cancer that you should know. I would throw this onto your cheat sheet. So self-sufficiency in growth signals, insensitivity to anti-growth signals, evading apoptosis, limitless replicative potential, sustained angiogenesis, and tissue invasion and metastasis. So going back to how RAS was a proto-oncogene, so normal RAS is okay. If you mutate RAS, then the protein that comes out is defective. And it's defective in that it keeps this system, this G protein coupled receptor system, always on. And so normally when you have a growth factor in the system, you produce some protein, or like growth signals. But then if you have an active RAS that will not turn off, then you're constantly churning out more growth. So RAS is important because it converts the GTP molecule, guanosine triphosphate, for GDP, guanosine diphosphate. And remember that GTP and GDP are completely different molecules. So in the diagram you see that instead of simply a phosphate group coming off, it's like an entire molecule that is different. So it's guanine nucleotide exchange, as opposed to like for ATP and ADP, it's like put on or take off phosphate group. Insensitivity to anti-growth signals. So this has to do with cell cycle regulation. So retinoblastoma, RB1, it's a pretty important protein because if your cell is not ready to go from like G1 to S phase, then it stops the cell right there and then. But if you knocked out both copies of RB1, then if the cell didn't properly have all the organelles ready, or like there was, you know, something wrong with like your cell and it wasn't like strong enough or had enough energy to replicate, then RB1 would be the one to stop that. So there's a difference between sporadic and familial cancers. So sporadic cancers are the ones that if you get a mutation, you're very predisposed. I mean, you're not as likely to get a second mutation. Like the likelihood is very low. Familial is like you're born with one, so the likelihood of you getting one is pretty high, and it's like 100% chance that like you will have that second mutation. Evading apoptosis. So p53 is the guardian of the checkpoint of the genome, basically, and it is responsible for regulating DNA damage. So if you see DNA damage come in, like p53 will, it's a transcription factor, and so it regulates like a whole bunch of different things involved in this DNA damage pathway. And so it'll tell the cell like, okay, you need to stop in this cell cycle so we can repair. And then if it doesn't repair, it sends signals for the cell to just die. So that's apoptosis, right? But if the cell, like if you mutated p53, both copies of it, then your cell is much more likely to just skip this whole apoptosis. So even if it's bad, it can like mutate to become all of this other like even worse cancers. So p53 is seen in like 70% of all cancers or something like that. It's like ridiculous. Telomeres, again, so they're the ends of your normal like chromosomes or DNA, and so when your DNA replicates, each time like the telomeres shorten by a little bit, and so after like 40 to 45 divisions for a normal cell, like that cell will just die because it's like, oh, you don't have any more telomeres, like, but cancer cells have the ability to build back those ends. So they can just tell themselves like, hey, we can still keep going. And so every time they replicate, they use telomerase to build back the telomeres, the ends of that DNA. You also have VEGF, which is vascular endothelial growth factor, and so it produces it makes blood vessels kind of plug into the tumor, and so it steals, like the tumor steals your nutrients, and it kind of takes oxygen and other factors and stuff from you. And this is why like you'll see patients can have like hypoxia in certain areas because like the nutrients are being taken up by the cancer. Cancers require tons and tons of your energy. And then this is metastasis. So a primary tumor, once it gets all those blood vessels innervating it, it can like, a piece of it can branch off and invade into the bloodstream. And so you'll see this embolism in circulation. And so this tiny little blood, like cancer cell, like will circulate into the blood, go in the lungs. So typically you see a lot of metastatic cancers go to the lungs or the liver. And then from there, it like can stick into the blood vessel wall of like a nearby tissue. And then if by chance it can get out of that tissue and establish what's called a microenvironment. So if like there's different growth factors in that new like a breast cancer found the necessary ingredients that it needed to live in the lungs, then like it can establish that microenvironment there, like, oh, I can live in this new place.
Mm-hmm.
And then it starts to proliferate and again get all of those blood vessels plugging into it, so then it can create a secondary tumor. So that's metastasis, and for metastasis you have to have collagenase 4, which is the one that helps to break down like the tissue when you're trying to break out of here into the bloodstream or into a new tissue.
Is it possible to get cancer in the heart?
I don't think there's many cases of that.
Okay.
Yeah, I haven't heard of anything like that.
Okay, just because when you were saying like because the blood flow like through the heart to the lungs,
Yeah, it's mostly like the lungs
weird.
where it kind of will get, yeah.
Okay.
So most of the time you'll see liver and lung cancers. And I think for bone cancer, like you can also get different bone cancers. I think it's from the breast and the prostate that can also go to bone. And so this is putting this all together. So RAS, a proto-oncogene, when mutated, becomes an oncogene, will give that cancer the ability to constantly grow. Retinoblastoma is a tumor suppressor gene, so when both get knocked out, you have insensitivity to anti-growth signals, so you can go through the cell cycle checkpoints pretty easily. P53, again, another tumor suppressor, when that's mutated, both copies go bad, and you can evade apoptosis. Telomerase builds back telomeres, so you can always replicate. VEGF, vascular endothelial growth factor for angiogenesis, so plug in blood vessels, and then collagenase 4, so you can plug in tissues to invade. You can break down other cells and stuff to get into new tissues and invade. HPV is another one of the well-characterized viruses that actually leads to cancerous growth. But besides that, it can also lead to just normal warts. So it promotes cancer by neutralizing retinoblastoma and P53. So E7, which is early protein 7, neutralizes retinoblastoma, so you have unmanned cell cycle checkpoints. And E6, early protein 6, binds to P53, so you evade apoptosis. And then concerning cancers, which is the following statement is true. So mutations in P53 leads to accumulation of damaged or mutated cells. The other ones are false because tumor suppressor genes are not overexpressed in cancers. Oncogenes are overexpressed. Germline mutations of P53 are the main cause of retinoblastoma. No, retinoblastoma is the cause of retinoblastoma.
Okay.
Yeah. permanent inactivation of a growth factor receptor would lead to cancer, you need a whole bunch of other factors to add to that. And also, if you inactivate a growth factor receptor, that's not necessarily like saying you promote growth.
Wouldn't that mean it wouldn't grow?
Right. So
Okay.
like, there's two ways to view that. Like, this is too vague of an answer, so you can't make any assumptions about like, oh, this answer is trying to get at something, so just cross that out. And then the last one, inherited mutations of oncogenes are a common cause of familial cancer. You have mutations of proto-oncogenes, which makes them an oncogene.
Okay.
So you get mutations in proto-oncogenes. That's the key.
Okay.
And then typically they're like tumor suppressors that you'll have the familial mutation in, like BRCA1 for breast and ovarian cancers. So, sorry. Yeah.
Sorry.
So you can have Pap smears to diagnose cervical cancers, and HPV is like one of the highest causes for cervical cancer. And so here, you don't need to know like which HPV causes what, but note that there's a difference between like HPVs that cause genital warts versus hand or foot warts, and then HPV 16 and 18 are the big ones that cause cervical cancers. So like vaccines, I think there's Gardasil and there's one more that confer resistance for type 16 and 18. So there's like a bivalent and a quadrivalent vaccine. And so bivalent means it confers resistance for 2 strands of HPV.
Okay.
Quadrivalent is 4 different types. Yeah, so like when they talk about vaccines in general, like how many different strains of like the flu are you immunizing, vaccinating against, like that kind of idea.
Okay.
Which of the following is an example of dysplasia? So it would be a wart. So the it's dysplastic but not neoplastic.
Mhm.
So like the cell type is kind of off. Does that make sense? Like sunburn and all of these kind of things, like they're not necessarily dysplastic, whereas a wart is dysplastic.
What about 1 and 3?
So 1, it's not dysplastic, it's just like you have more cells or something like that, or like it's just the cell is like worn down more.
Okay.
And then 3 is I think it's metaplastic is the word, when it
Okay.
converts from one cell type to the other. Yeah.
Okay.
And that's all of this info is found back in your first lecture.
Yeah.
Yeah, very first lecture. From this slide, just know that like cancers, they can relapse if you don't fix it, and then you know, sometimes there's chemo, sometimes there's like cutting it out, and if you don't surgically remove it at times, that could lead to death if it gets to like a certain mass. Adverse effects of chemotherapy, I guess the main idea is you can have like most damage to the cells that divide the most. So your GI tract has a lot of mucosal cells, so like they won't secrete things as easily. Your bone marrow, that's where all of like your blood comes out of, your blood vessels, blood cells, I mean. So you can have anemia or neutropenia, so you have like deficient oxygen capacity in the body. Hair follicles, like hair, because it grows. Skin, because like it won't grow very well. And then lastly, the fetus, it's very bad for pregnancies. Chemotherapy is like, because they target cells like in cancers, are very prone to mutations. Like the way kind of the idea of natural selection, like the most fit ones survive, so the ones that like survive the chemo most likely have resistance, and then like that population kind of grows and grows until you have chemo resistant cells. And then cancers can also kind of mess with your body by making you produce lots of like cytokines and chemokines, like toxic fairy dust, I guess, and they can avoid your immune system pretty easily after a certain point. And then cachexia is like another side effect where because of all that malnutrition, you have wasting away, you lose fat tissue, and like generally cachexic like cancer patients, they have lower desire to eat, lower appetite, and also like they are actively losing their nutrients to the cancer. So 2 ways that it leads to cachexia.
Okay, I have a question about the previous slide.
Yes.
Yeah, that one. I could be wrong, but aren't cytokines and chemokines like part of the immune system with dealing with like infection and stuff?
Yeah, so it's just like the idea that cancers, like they can kind of secrete things that you normally wouldn't, like a normal cell would not be able to secrete. So this is just an example, like they could secrete things that your body, like that normal cell would never secrete ever, but it could just be a random cell that like happens to make some of that.
Okay.
But also like cancers, because they are your own tissue, like your immune system starts to like not be able to recognize them as like a foreign cell because they happen to have some of the same markers as your cells. And, yeah,
So how is it bad that it's releasing those?
So
Like
sometimes you have cancers that are associated with inflammation. So it's like high levels of inflammation that's not triggered by your body. It's like the cancer makes this stuff that makes your inflammatory system really crazy and haywire.
Okay.
So you're constantly in this like very distressed, energy needing system.
Okay.
Yeah. So the endocrine system, like the way I think about it is you've got like the hypothalamus or the hypothalamic pituitary axis. And so these 2 regions of the brain send signals to different organs around the body, and then the signals that are received make those organs produce the endocrine hormone that you want. So the biggest idea from this lecture is like feedback mechanism. So if you have enough of that hormone in the system, then your brain won't do anything. But if you need more, the brain senses it and will send signals to your organ to make more hormone. There's different parts of the hypothalamus. So there's the anterior pituitary, which produces flat pig. So FSH, LH, ACTH, TSH, prolactin, that's the PI, and G, which is GH, growth hormone, And then intermediate pituitary produces MSH, and then posterior pituitary produces ADH, so antidiuretic hormone and oxytocin. The thyroid produces thyroid hormone, parathyroid produces parathyroid hormone, adrenal cortex produces your different like corticoids, so mineral corticoids like aldosterone. Aldosterone is for sodium retention. Glucocorticoids for cortisol, which is to kind of process glucose metabolism, and weak androgens for like secondary sex characteristics. The adrenal medulla produces epinephrine, norepinephrine, dopamine, and that's for like your sympathetic nervous system. Pancreas for insulin, glucagon, somatostatin. So insulin is the biggest one. Like you'll talk about diabetes in your next lecture. And then ovaries and testes for those sex characteristics. So going over this chart, I think the idea of this chart is pretty important. Like you can reformat this table into like boxes on a Word document or something that better represents all of this. So like I would look mostly on this level where anterior pituitary hormone is. So it's like flat pig. It's just rearranged differently. So FSH and LH is stimulated by gonadotropin releasing hormone by the hypothalamus. And so FSH and LH act on the ovaries or testes to produce estrogen, that's the estradiol, and testosterone. Growth hormone releasing hormone produces growth hormone, which growth hormone acts directly on tissues, but also stimulates the liver to produce insulin-like growth factor 1. Dopamine acts for prolactin secretion in the breast for milk synthesis, not secretion, and CRH, and I think it's what does CRH stand for? I think it's corticotropic releasing hormone or something like that. Adrenocorticotropic thyroid hormone. No, it's not. Adrenocorticotropic hormone, I think. ACTH. Stimulates the cortex for cortisol and aldosterone and other things like that. And then lastly, TSH, thyroid stimulating hormone for the thyroid, and T3 and T4, metabolic hormone. And we'll talk about all these soon. So the thyroid hormone, T4 and T3. So T3 is the active form, even though T4 is the most abundant form. And so thyroid hormone is good for like general growth, metabolism, heat production, oxygen consumption. So when your thyroid goes down, your general metabolism is off. So then you'll see, okay, first the feedback loop again. So hypothalamus realizes you need to like make more stuff. So then it acts on the anterior pituitary to tell the target organ, make more hormone. If you made more hormone, it tells the anterior pituitary enough is enough. If not, you keep going for more. That's kind of the general idea of like negative feedback loops. Parathyroid hormone is also made by the parathyroid, and we talked about this a couple weeks ago, where you can make parathyroid hormone to build back calcium. So if you have low serum calcium, you want parathyroid hormone to stimulate your intestines, kidney, and bone to say, hey, like, let's make more calcium, or let's make more calcium in the intestines by reabsorbing it, or let's not release it so much from the kidneys. And remember, you release calcium in the kidneys, but you get rid of phosphate as a result. And then lastly, you can break down bone as well for calcium. And then also synthesis of 1,25-OH2-D3, that's vitamin D. So you make active vitamin D in the kidneys. And then this makes more calcium, and then you're done. Calcitonin is the exact opposite. So if you have too much parathyroid hormone, you can use calcitonin to like increase how much you get rid of calcium in the intestines, kidneys, and you also put it back to store in the bone.
Okay, so it does the opposite of PTH.
It does the opposite of PTH. But typically, like, you'll just have less PTH in the system rather than secreting calcitonin. So it's more like, yeah. Normally it's like PTH is the one that's like regulating everything. Yeah. The adrenal cortex, it's good to know that there's like these 4 general layers. I mean, the adrenal gland has 4 layers, so it's adrenal cortex has 3, and then adrenal medulla is the inner layer. So the medulla secretes norepinephrine, epinephrine, and dopamine for like that general like sympathetic activity, like, you know, you need more energy, or like adrenaline, that idea. Whereas the cortex is more for like general kind of stuff, like zona glomerulosa is for aldosterone, your mineral corticoids. Zona fasciculata, that's the second layer, that's for glucocorticoids like cortisol. Reticularis is for weak androgens like DHEA, for like secondary sex characteristics. Okay? And then the medulla, like the ones that they secrete are catecholamines, which are epinephrine and norepinephrine. So adrenal glands, so adrenal cortex, and I think the way to know all of these, like either you can put it into your cheat sheet in like a nice organized table, or if you memorize these pretty well, like all the different things that we'll come across, all the diseases, like it's good to just like if you know the function of each hormone, then the associated symptoms and stuff like that come a lot easier.
Okay.
So we'll see charts coming up, and I think those charts are helpful to like break down it's this versus this. But try to memorize what each hormone does so that it can make your life a lot easier.
Okay.
So aldosterone remembers for the renin-angiotensin-aldosterone system. So it's to retain sodium, and if you retain sodium, you increase water, and if you have more water in the system, you increase blood pressure. So that's what aldosterone is for. And that's kind of like this in a nutshell. But like, if you have a lot of ACTH, have a lot of potassium, hyperkalemia, because you get rid of potassium to store the sodium. And if you have low sodium, all three of these can make you have more aldosterone in your system. You can have the zona fasciculata for the glucocorticoids, and so they're for carbohydrate metabolism and for anti-inflammation and suppressing growth, and also it's for like general sleep habits and awareness. So cortisol, important for all of those factors. So yeah, like low oxygen, low glucose, low heat or high heat in the system, like hot, and then exercise can make you want more cortisol in the system. Better metabolism, better energy, things like that. Pituitary pathology, so hyperpituitarianism, so more pituitary, so like you're producing too much of something. So all of these are just different cancer types. Hypopituitarianism, so because if you could have a null cell adenoma, so it's a cancer that doesn't actually do anything, but it takes space away from other parts of the brain that need to do something. Ischemic necrosis / Sheehan and ablation, and then posterior pituitary syndromes, central diabetes, and SI-ADH, syndrome of inappropriate ADH, and oxytocin deficiencies. So like sometimes like these lists can be helpful for like just a general chart if you're trying to map out what everything does.
Okay.
So diabetes insipidus, so you don't have enough ADH, versus SI-ADH is too much ADH, but it's like two ways that the posterior pituitary can go wrong.
Okay.
So if you have diabetes insipidus, if you don't have enough ADH, you're not holding on to water as well as you should be. So then if you're not holding on to water very well, then you have polyuria, so a lot of pee, and polydipsia. I think that's increased thirst.
Yeah, I think he said it's like drinking lots of water.
Yeah. So you want to like replenish all the urine that you're losing, and that urine is very dilute, whereas your blood is pretty concentrated because the system doesn't have much liquid, but your urine has a lot of volume. And then it can be a neurogenic, so a brain problem, so not enough ADH, or it could be nephrogenic, so like your kidneys don't respond to the ADH.
Okay.
SI-ADH, so if you produce too much ADH, you can secrete all that out, and you can have normal adrenal and thyroid function. So you'll have hyperosmotic urine because you concentrated so much of your water in that anything you do urinate out, there's not much liquid, and if there's not much liquid, then there's a lot of solute per volume. Anterior pituitary, so this is like all the flat pig stuff. So we'll kind of just go into that now. So hyperpituitarianism, so you can have like a cancer just like right in the middle of like your brain, which can lead to visual defects. So you'll have the word is bilateral, so both sides, temporal hemianopsia. So you see or like don't see one side of like each eye. And so kind of depending on where the cancer is located, it cuts off to different kinds of blindness. So if it's at the optic chiasm where the two eyes cross, because like left eye, right brain, right eye, left brain, if it cuts off right in the middle, then you have like blindness at like the outer regions of the brain, but not like you can see like the inner part
Okay.
throughout both eyes. So this is showing like what you can and can't see in the white versus black. Like, so if it was cut off here, you just don't see the right eye.
Okay.
If you had a tumor here, you can't see the right side out of both eyes.
Okay.
Yeah. Yeah, and null cell adenomas, they don't secrete anything, they just take up space. Acromegaly, so growth hormone, if you produce too much, it can lead to acromegaly or gigantism. So acromegaly is during adulthood, gigantism is for children or adolescents. Hyposecretion is pituitary dwarfism. So remember back, there's achondroplasia, which is a type of genetic dominant, autosomal dominant disorder that leads to like dwarfism.
Mm-hmm.
But this is the endocrine version of that. So the other was genetic, this is endocrine. And then if you have it more like decreases in growth hormone as you get older, leads to like aches and pains. So this is just like a picture of that. So growth hormone can stimulate your tissue directly, or it stimulates your liver to make insulin like growth factor 1, which makes more stuff like tissue growth, skeletal growth. So dwarfism, gigantism versus acromegaly. Next we have prolactinomas. So if you have too much prolactin, so prolactin again is for like milk production synthesis, not secretion.
Mm-hmm.
So in females it can lead to amenorrhea, galactorrhea, hirsutism, osteopenia. In males, hypogonadism, erectile dysfunction, impaired libido, oligospermia, and diminished ejaculate volume. So like both of these, if you have too much prolactin, it can mess with those like things associated with like sex characteristics, things like that. Thyroid pathologies. So I would say this chart is probably more like this list is probably better for your cheat sheet than the other ones, because like Graves' disease and like it's Graves' disease is hyperthyroidism versus Hashimoto's thyroiditis, hypo, and I feel like sometimes these thyroid ones get mixed up easily.
Okay.
But we'll talk about them soon. And then carcinomas, there's different types. So you can have a non-functional papillary carcinoma, 15% are follicular, 5% medullary, and there's rare anaplastic cancers. I think it's good to note these 4 types as well. I don't know how specific a question you get, but like to be able to identify that these are different types of thyroid cancers.
Okay.
Yeah, so this chart is pretty good to know that like it kind of puts everything into better perspective. So if you have too much TSH, thyroid stimulating hormone, you would see that with high TSH, and because you have high TSH and normal thyroid, then like you have too much T3, T4. If you had thyroid dysfunction like Hashimoto's thyroiditis, where you actually attack your thyroid, then like no matter how much TSH you make, because your thyroid is damaged, you can't produce T3, T4 because you're not sensing that you have a signal to make more. Thyroxine production, so Graves' disease, you have antibodies against TSH, so you're producing T3, T4, but your body is telling you to stop, so you have TSH telling you like to calm down, but you have like Graves' disease, like too much production. And then pituitary dysfunction is like less of both. So hyperthyroidism, like if you had a very high metabolism, let's say, like you have lots of weight loss, sensitivity to heat, irritability, anxiety, And you treat it with beta blockers or anti-thyroid medications. Hypothyroidism, you have myxedema, which is an important one to know, puffy face, constipation, sensitivity to cold, weight gain, and also cretinism, like mental retardation. And you treat it with levothyroxine, which is a synthetic form of T3, T4, like hormone, and then iodine for treating that iodine deficiencies. So Hashimoto's is a type 4 chronic thyroiditis, hypersensitivity, sorry. And so basically you have antibodies against your thyroid, and because you have antibodies against your thyroid, then you have low secretion of T3, T4, but high secretion of TSH. Cretinism, so low iodide can lead to goiters, like these huge things, and also mental retardation for children. Again, PTH, calcitonin. So if you have too much PTH, then like you can break down your bone too much and reabsorb too much calcium. So this is pretty much what this chart is saying. Like, depending on if you have a lot of calcium or not a lot of calcium, like, do you have a lot of PTH to go along with it? So primary hyperthyroidism, you have PTH secreting hormone, tumor that makes a lot of PTH. If you make a lot of PTH, you get a lot of calcium, but in exchange for calcium, you got rid of phosphate. Secondary hyperparathyroidism is like if you had a vitamin D deficiency or renal failure, so you don't have much calcium, but you do have a lot of PTH in the system. A different type of secondary hyperparathyroidism is elevated phosphate, but also elevated PTH but decreased calcium overall, so lots of parathyroid hormone. Primary hypoparathyroidism is damage to the glands, and so you have low PTH, low calcium. And then secondary, if you have increased bone breakdown or metastatic bone cancers, like again, you have a lot of calcium but not much PTH.
Okay.
Yeah. Here, like, if you have a lot of parathyroid secretion, you have a lot of this calcium in your blood, but not seen with secondary hyper PTH syndromes. You can get rid of a lot of calcium in your urine and have kidney stones and like thin bones, osteoporosis. And you can cut out like one of your parathyroid glands.
Okay.
So because of too much PTH, it can lead to stones, moans, groans, and bones. I don't know, these 4 things. Adrenal glands, you can have problems with too much adrenal gland stuff. So like Cushing's disease is too much cortisol. Hyperaldosteronism with Conn syndrome, too much aldosterone with Conn's, or adrenogenital, so problems with the adrenal secondary sex characteristic stuff. And then adrenal hypofunction. Addison's disease is an insufficiency for all of them. So Cushing's disease, like you can have a pituitary Cushing syndrome, so there's a cancer in the lungs that makes you produce too much. You can have a cancer, or like, I think this is the brain. Yeah, the brain is making too much ACTH to make your organ produce too much cortisol. Adrenal Cushing's syndrome is like the cancer produces a lot of cortisol, so then like you have low ACTH but high cortisol. The first one is like high ACTH, high cortisol. Paraneoplastic is like high ACTH, high cortisol, but like the source is ectopic, so it's not in the brain. And then iatrogenic is like because you took pills or medicine or something like that, like it's drug induced or like the hospital caused it. Like something outside of the body caused it. can lead to a lot of Cushing's. I mean, yeah. So with Cushing's, you see a moon face and buffalo hump and purple striae and hirsutism. Those are like the 4 keywords I would say. So moon face, your face is round. Buffalo hump, like you've got like a fat pad over your shoulders. Striae are purple stretch marks, and then hirsutism, like lots of body fat, body hair. And so like this is a picture of it. So I'd say like the pictures do help to like remember the syndromes, because sometimes they'll ask you to identify like which one of these is most likely to
Okay.
cause. So if you can identify the symptoms, then it helps.
Okay.
Conn syndrome is too much aldosterone. So if the tumor made you have too much aldosterone, your blood pressure increases because you act in the RAS system. So like a lot of aldosterone, more sodium, more water, more blood pressure. And then more blood pressure, low renin, because it like feeds back onto your kidneys, but then you have the tumor still making more anyways. And then you have adrenogenital syndrome. So if you have a deficiency in this 21 hydroxylase, then you can have deficiency in like how much DHEA, like those secondary kind of other things like that, testosterone, estradiol. So you'll have virilization, so you can have hirsutism, again, so like excess body hair. So yeah. Addison's is what JFK had, so decreased of all of those adrenal cortex hormones, so hyperpigmentation, darkening of the skin, hypoglycemia, low blood sugar because of the low cortisol, nausea, depression, things like that. And then lastly, adrenal medulla pathologies. So pheochromocytoma is like an important one to note. So because I think people forget, like it's like the last one, but it's a lot of, so the chromaffin cells of your adrenal medulla has a cancer in them, and it produces too much epinephrine or norepinephrine. So imagine like if you were like jacked on adrenaline, what would you be like? You'd be very jittery, very anxious, very frightful, high blood pressure, a lot of pain, excessive sweating, and you have to have like beta blockers to calm them down.
Okay.
Yeah. So that's like all of endocrine.
Okay.
Yeah. Do you have any questions?